Hello, Dr. Brett Sanders here. Thank you for allowing me to speak to you about modern arthroscopic transosseous rotator cuff repair with the Tensor Surgical Repair System. I do have a relevant disclosure. I'm the founder and inventor of a reusable transosseous repair device that we're going to be discussing today. When I first started this journey, it was about value, as defined by the Harvard Business School as outcome over cost per episode. I know in single payer systems in countries where there's single payers and in bundled payment arrangements, there are many situations where the cost is a problem, and we're trying to address that. Simultaneously, there's been technological convergence and commoditization of anchors that we use. So they're basically all the same. And if you can provide non-inferior outcome, it doesn't even have to be superior, equivalent or non-inferior, and cost effectiveness, then you've practiced value-based medicine. And the shoulder is a target-rich environment for this practice. Dr. Codman, the pioneer of shoulder surgery, was studying value back in the early 1900s. And this actually got him removed from Mass General Hospital when he was talking about it, but he's become the father of modern value-based surgery. Let's talk about the ideal repair. What are we after? Well, these are the principles of Christian Gerber. Initial fixation strength needs to be high enough to resist cyclic failure and ultimate load to failure. We need to prevent gap formation and shear forces, and we want to restore the footprint. And many times to restore the footprint, we need to have multiple fixation points to be able to reduce the bird beaks and dog ears, more fixation points than the cost would allow in many cases. We also want to improve or respect the biology and be mindful of these bone voids and the healing that the tuberosity imparts to the rotator cuff, and it needs to be easy to revise. We need to be mindful of this anchor specific failure mode, which is the type 2 failure that can be catastrophic. And we might have some improvements there with transosseous techniques. And we also need to be cost effective, and we need to have good clinical outcomes, and we have data that's coming out on this. I would like to also introduce some new ideals perhaps. We need to look at the healing characteristics on MRI and ultrasound and have these tendons heal as biologically as possible. We want to be able to use our biologics and our patches with transosseous repairs under a cost ceiling so that we can actually use them and not break the bank in the process. We need to have improved vascularity, and we know that there's evidence showing that there is improved vascularity with transosseous repairs compared to transosseous equivalent. We want to also restore the footprint, and there's no question, Ty Lee has redone this biomechanics from earlier, that the transosseous cerclage effect is the best way of recapitulating the footprint. This is the best way to tie the tendon to the bone. And I would like to say that load sharing is a very important concept here. You see, we can push the balloon down on multiple nails and it won't pop. It's the same thing with the rotator cuff tendon, instead of having pressure spikes that will tear the tendon. Now, Randelli and Castagna in Italy have introduced me to this transosseous repair cycle, whereby we started with open transosseous repairs. And there's a logical progression back to transosseous arthroscopically. So we went to mini open transosseous, mini open with anchors. And then when we went to arthroscopic anchor repairs with single row, this is where we got into trouble. We had worse structural healing. And then we had to add a lot of cost and anchor voids and tendon transecting failure modes to catch back up to what the transosseous cerclage effect was doing anyway. Many hours have I spent working on these hybrid techniques, trying to step surgeons in at this step back to fully transosseous repairs and get back to this concept without the hardware. Now, when we first started doing arthroscopic single anchor cuff repairs, as I said, the re-tear rates were way worse. And as to why that happened, whether you're a biologist like Dr. Snyder here or a biomechanist, your answer would differ. It's either tension and biology or inadequate footprint reconstruction and biomechanics. Well, some smart people came up with the transosseous equivalent as an answer to this problem. And they say right in their paper, transosseous equivalent attempts to recreate the traditional open transosseous cerclage effect. They say it right in their paper. Now they were comparing, this was a purely biomechanical thought process, and they were comparing this to double row anchor constructs, and they found higher load to failure and less gap formation. Incidentally, they consider that only about 300 newtons of force is necessary for the repair to heal, because that's the theoretical maximum supraspinatus contraction. And the advantages that they tout in their original paper are lower profile knots, not relying on the torn tendon edge for fixation, reduced surgical time. This has been shown independently by Dr. Lazarus for transosseous and anchor-based repairs to be equivalent in the OR. Placing anchors outside the healing zone and increasing the healing surface. Well, I totally agree. And true transosseous repairs are way better on that regard. Load sharing, interconnected fixation points, and lateral fixation on the humerus. Well, this can all be done with transosseous or transosseous hybrid or both repair constructs. So just using principle-based thinking here, let's take it to the next level. So here's a hybrid technique which was described in 07 already, AJSM, with about 400 to 500 newtons of repair strength. And this was the first one I did, I just recapitulated this arthroscopically. And how you repair a tendon just depends on how the surgeon wants to optimize for time, cost, fixation, usability. There's more than one way to skin the cat. In terms of biomechanics, this slide is a picture of Dr. Cole's slide from the ESH meeting a couple of years ago. In the green box, you see transosseous equivalent with anchors has an ultimate tensile strength of 350 to 400 newtons. And Bernie Bach and Gus Mazzacca have shown with this study, using all suture, they were able to essentially double that, 856 newtons of failure strength. They were ripping the surgical necks off the humerus. So you can clearly get strong repairs with all suture. And this is my version arthroscopically doing this transosseously with a hybrid technique. Now, as we've established, the transosseous repair is the gold standard, but there's a lot of interesting points to make in the modern era about biology, pain, biomechanics, revision considerations, and we've got more outcomes data and also utilization of the technology with other fixators. There's been a lot of attempts at this throughout the years, but the one we're talking about today is the Tensor Transos device, which addressed the primary problem with most of these approaches, which was usability. They were simply difficult to use. And this is a reusable design, so it's cost effective, it's very robust, and it has excellent accuracy and usability in one-handed operation. So you can make a tunnel in about 20 seconds. It's a 2.9 and a 1.9 millimeter hole in the bone, one-handed operation. You can make unlimited fixation points within a case. It includes a suture kit, and you can use it with anchors or not, or tapes or screws or anything you wish to. In terms of how do we adopt these techniques, in the red boxes, this is what we tend to talk about at meetings: safety, efficacy, clinical biomechanics, biology. But really what I've found is that it's mostly psychosocial factors that determine adoption, health system, your incentives and your payer mix. But a lot of it's just having friends and peers that are interested in it. And this is my friend, Dr. Castagna from Italy, and they have a grassroots interest in transosseous repairs as well as the South Americans. So this is a burgeoning paradigm. The biomechanics of transosseous repair are different. They can be as good or better on the conventional parameters, but they're different. They don't make this stress riser in the tendon. In fact, transosseous alleviates the stress riser. So the failure mode is different. This is very important for revision. Scott Rodeo has shown, among others, Sri Krumaran recently, that it's really the number of sutures that determines the strength, not the number of anchors. So we really need to be talking about fixation points per surface area and number of sutures per fixation point, not rows or number of anchors. And now that we can put in a lot of sutures we can achieve very strong repairs. Now, in terms of biology, here's a view of the totipotent stem cells coming right out of the tunnel. And we have these bone marrow vents, which are the only thing that's really been shown to improve healing in the rotator cuff. And we've seen from Dr. Mazaka's work that there are stem cells in the greater tuberosity. And we're able to increase the cost ceiling so that we can bring in our new biologics, patches, BMAC, and other things, and again, be under the cost ceiling. Bone marrow vents and vented anchors have been shown to create thicker healing in the tendons, and again, better vascularity with transosseous repairs has been shown arthroscopically. In terms of value, there's just no question double row has been shown in JBJS to never be cost effective, and transosseous repairs are clearly more cost effective, and there's really no discussion about that. It's been shown in the literature. Now, let's talk about some clinical factors. This is an interesting case where I used anchors and tunnels together, and we can see the healed transosseous repair in the front here, where the tendon is essentially growing into the bone marrow vent. And here's the medial row anchor that transected the tendon. So this patient fell, and the anchor transected the tendon, which is the catastrophic failure mode. And this is what happens to your anchor. It fragments, creates a bone void that you have to deal with. And I ended up revising this by placing tunnels in that bone void and then placing anchors where I had the tunnel. So here's where the anchor pulled out. Look at the size of that hole. And then you'll see right next to it, here's a tunnel. And the bone has grown right back to the suture, and you can do anything you want there. You can put another tunnel in, you can put another anchor in. Here's an anchor fragment down in the shoulder that you'll have to remove. When a suture cuts through, you don't have to remove any hardware. And here's in the front, you can see the tendon growing into the bone marrow vent there. So this is the biology that accounts for this clinical evidence, which is excellent. The re-tear rates have been excellent, as described by Kuroda, Srikumaran, and others. Very high ASES scores postoperatively, very high satisfaction, all with decreased cost. And this has been shown with 2-year ultrasound control by Dr. Srikumaran in this study. And there's another one that just came out in 2020 showing the same thing. Now we've got long-term results as well, 12 to 18-year follow-up with mean ASES of 92. And this is exactly what I found in my pilot series with my data as well. So 27% repair failure at 18 years, that's not bad. I think any technique would be good to achieve that. Now, interestingly, there's level 1 evidence for less pain with transosseous repairs, and we are seeing this for sure. And what happens is when you switch to transosseous, the physical therapist will call you and say, why did your cuff stop hurting? And I hear that time and time again from surgeons that change over. And this has been shown abstractly with level 1 evidence here, but let me tell you, it happens in the clinic, and it's amazing. So I think we have opioid-free cuff within striking distance here based on this. And why is that? Well, we think it's because when you put anchors in, there's engorgement of the bone and increased intraosseous pressure, and it creates fracture physiology for about 6 months. And when you vent the tuberosity, you have decreased in pressure, as you can see by the bone marrow coming out of this bottom picture here. So they're simply less painful from the get-go, and they don't struggle like the traditional transosseous equivalent repairs. And this has been shown with a recent study, 2020, showing 6 months of bone marrow edema. And this is why patients hurt, probably, or at least one of the reasons why they hurt, that we can address now. So this I'd like to show you is the true transosseous hybrid technique that we discussed earlier. So this is a way for surgeons who have concerns about jumping into transosseous repairs arthroscopically. I designed this technique to address the common concerns of bone quality and tensioning and knot tying. So this construct you can see in the cartoon on the bottom left has no anchor burden at the footprint, only microfracture vents. It's triple row. There's cortical augmentation if you're worried about bone softness, and you have a second chance at tensioning the repair if you're worried about tensioning or knots. And you have improved cost ratio for multiple fixation points. So we're getting 5 fixation points with only 1 anchor. And we could easily take that to 7 or 9 by adding more tunnels. This is also a self-reinforcing construct. So when the tendon pulls perpendicularly, it actually compresses the tendon down to the bone more. And this is what it looks like. You would think there was multiple anchors in there. There's no anchors in there in that healing zone. So this is a true transosseous hybrid with one anchor down laterally, triple row, 5 fixation points. This is the outcomes of this technique, 14-month follow-up, 143 patients. We had 4% re-tear, and these were falls in large part. And we saw a 44-point increase in ASES scores. And you can see on the bottom right, this is a SOS data of pain scores early when you switch to the top line as anchors and the bottom line as transosseous. When the surgeon switched, the pain just drops by like 2 VAS points. And so we're getting excellent results here with this technique. I'll take you through the first-person view here in the OR. We're cleaning out the lateral gutter here, and we'll show how easy this is to deploy. Here's the transos. We're going to introduce it inverted through a small portal anterolaterally. We pop through the subdeltoid fascia, and we're going to rotate up and find the medial 2.9 millimeter hole, which we had already created with an awl. We don't drill any bone or remove any bone. It's all awled to maintain the strength of the tunnel. We're going to rotate down. You see, I can even let go of it with one hand while the assistant hammers the awl in, and then we back it back out. And it's that fast. It takes about 20 seconds to make a tunnel, and there we're done. We're going to use this passing suture to, in this case, pass 3 more sutures. You could make a racking hitch out of that suture. There's multiple different ways to repair the tendon. Here we're going to pull a triplet or 3 sutures into the tunnel, and we manage that topographically. So what's happening on the outside with the sutures is happening on the inside. So we clip them to the coband statically with these suture organizers, and then we clip them in sliding mode dynamically up to the drapes so they can slide. And this makes it so that your suture management is not a problem. The next step will be to put the other tunnel in, and that's what it looks like. You can see it looks just like anchors there with sutures coming through. And then we're going to put our cannula in to exclude the tunnels, to exclude the sutures, sorry. And now we have a suture situation that is exactly like anchors. So you can pass your sutures through your tendon exactly how you desire. And then here we're going to retrieve the sutures. We're going to link the tunnels here. Some surgeons have concerns about knot tying, so we're going to tie the knots outside the body, and then we can bring them back in through the cannula, and we'll tie those and bring them back in. And interestingly, you can put the knot stack where you desire for maximizing compression and make it look good. And then we're going to tie the simple suture here. I use an SMC knot, a sliding locking knot, putting the knot low and lateral, so I like to keep them off the top of the tendon. Here we can put the knot stack where we want it for the best repair, and this will allow the best compression of our tendon. I'm going to fast forward a little bit here for the sake of time. So here is our transosseous repair. You could stop there, but we're going to grab the sutures. You see the stability there with the shear reduction. And here we've left the tails long, and we're going to retrieve these sutures which we've left long, and we simply put those in a knotless anchor and bring that anchor down low and lateral and put it inferior to the horizontal limb. And we put that in, and there's our true transosseous hybrid, where we have no anchors at the healing zone and multiple fixation points with suture. You see excellent reproduction of the footprint anatomy there. So in terms of clinical pearls for small tears, POSTA repairs, this is the video in the top shows a single tunnel, and I tend to use Mason Allen sutures, but you can get excellent reproduction there for small tendon tears. For a single tendon like a supraspinatus, I usually use an X-box, as you can see here, and this one has a racking hitch next to it. And for a single tendon, that's a good construct. And then for larger tears, I use 3 tunnels, And I call this a double box, but we're able to get excellent reconstitution here with tapes and a double box configuration in this repair. And here's a true transosseous hybrid in a larger tear with 3 tunnels. And we can see how we can get these excellent types of repairs. A common question is about bone mineral density. Here's this nomogram. Bone mineral density is a Gaussian distribution. So when the bone density is good, all fixation works. When the bone density is poor, all fixation will fail. And the ramifications of a suture cutting through are much less than an anchor pulling out. When you have this intermediate zone is where I like to use hybrids or augmentations perhaps. There's so many different ways to treat cuff tears now. We simply don't have a lot of problem with bone cutting through, with sutures cutting through, probably because the 80-year-old irreparable tears are getting reverse arthroplasties now, and there's a lot of tears happening between 40 and 75, and so the bone there is just quite good. There's also a trend towards fixing smaller tears in younger patients before they become irreparable. In addition, we have some device-related design concepts, such as not using drills and so forth, that makes it so that the bone is maintained. This is the softest bone case I've had, where the bone was just like butter, incredibly soft. And there was a 18-millimeter bone void where the bone had pulled off. And here we used a plate. You see that bone void in the top. We used an ACL button to achieve the fixation you can see in the bottom. And this was an advanced technique, but you can see there's a lot of different ways to deal with this. This patient fell and tried to fracture the tuberosity, but it held post-operatively. But it just goes to show you that there's more than one way to fix these problems. Here we're using cortical augmentations with plastic PEEK inserts to repair a cuff. So we can augment the bone in various ways. I know many Mexican surgeons have been involved with Zip Tech and the development of that device. So here we've used Zip Tech with Tensor and created a transosseous button repair on both sides of the tunnel. So I think this is a very interesting technique and a lot of synergy here, where we can get this excellent footprint reconstruction using synergistically these technologies. I would like to show you as well some clinical advanced cases that just to get a glimpse of what's possible. This is a biceps autograft for a superior capsular reconstruction that we've controlled and placed and set the tendon transosseously. So this is a hybrid technique, but there's some advantages by working transosseously with managing these grafts, where you don't have to measure them as precisely, and you can pull them into the tunnel and use manual tension to seat them, and also not have as much cost in the case. Biceps tenodesis. Here's an example of tunneling in real time with no editing in the front of the shoulder. The bone in the biceps groove is always very hard. Here, this is a neat technique. We're intertwining our sutures. Because of the design, we can work around hardware and work around sutures and split sutures and intertwine them in this manner. And here we're putting a tunnel in real time, and that's how long it takes. And you can see the biceps tenodiced anteriorly, and this construct is quite strong. I've had very few failures with this. And you can see from the top two pictures on the right and left, there's a lot of different ways to cerclage the biceps, and you can see the cosmetic result on the right. Here's a true transosseous repair. This is written up in arthroscopy techniques as shown, and you can see the quality of the repair with the biceps tenodiced as well. So that's 5, 6, 7, 8, 9 fixation points in that repair with one anchor only. Here's some more interesting techniques where we had an irreparable subscap tear, and we're using a strip graft here to repair that. So there's a strip graft in a subscap which has been repaired, and you can see it looking from posteriorly. There's the subscap repaired. it was irreparable, it wouldn't reach. And here is the strip graft on the right attached to the bone tunnel. Here's an example of allograft augmentation of a borderline irreparable infraspinatus you see on the top left. Here we're pulling a strip graft into the tunnel manually and passing it through the tendon to bridge, and using that to further bolster the tendon. And we're going to pull this and use it to reduce the tendon. In this particular case, we did a biceps autograft superior capsular reconstruction as well. So we're adding these things together and using them together. And here's the final repair with all biologic healing in the tuberosity. So there's no anchors in that tuberosity. There's the graft adjacent to a biceps tendon autograft. So these are just glimpses of the future. I think this can eventually compete with superior capsular reconstruction and other repair modalities, but it offers us a lot of interesting ways to tension grafts and add in biologics. So as a summary, to go over, we've got some exciting new developments in transosseous cuff repair. We have essentially equivalent or superior outcomes: biomechanics, ease of use, and time. We have less type 2 failures and less pain postoperatively. We have documented decreased cost and fixed cost reproducibility within a case. There's improved biological considerations with improved blood flow, improved revision considerations in terms of bone voids and lack of inert material in the healing zone. There's better MRI healing characteristics with less Sugaya 3 healing of the tendon. We can use with anchors or without anchors or other technologies. So we can use transosseous to synergize with any other technology you care to use. But we can have unlimited fixation points within a repair, and we can increase our fixation point density in the repair, more importantly. We can maximize the outcome and minimize the cost, all while bringing in the next stage of rotator cuff repair, which is biologics. So with that, I appreciate your time. And I have my contact information here. If there's any questions, you can email me below. And our website is tensorsurgical.com. There's many videos and resources and links to papers and data on that webpage. And we look forward to hearing from you. Thanks.